Hello.
Yes, sir. It is just getting sorted. We also have the technical person in the meeting as well.
Okay. I'm afraid most of our listeners would be sleeping by this time.
Yeah, sir.
Mm. You're from Hyderabad?
No, sir. I'm from Mumbai.
I hope that this seminar or whatever conference, it should not act like you know नींद नहीं आ रही थी तो लोरी के जैसा काम आ गया.
Yes, sir. It won't be. I'm sure for sure the resistance would come up, and they do have.
Sorry, what did you say? I didn't get you.
Okay, sir. So in about 20 seconds, we'll start. I'll just introduce and start with the event, and you can start with your presentation. Okay, sir?
Okay, right. So it will be like 20 minutes presentation followed by question answer session.
Yes, yes, yes. After your presentation, sir, there will be question answer round in which I'll be reading out the comments that have come up. Okay?
Okay, right. Sure.
Okay. So good evening, everyone. I welcome you all to this ENT Head and Neck Pearl series. I'm Shreyas, Endocrinology and Diabetology Community Manager at Medisage. Medisage is your one-stop stop for high-quality medical knowledge. We have almost 8.4 lakh healthcare professionals associated with us on our platform, and more than 5,000 ENT specialists on our platform as well. Medisage provides a variety of content to healthcare professionals in terms of webinars, articles, blogs, and case-based learnings as well. So I'm honored to welcome you all to Dr. Y.L. Ravi Jadhav, a consultant and ENT surgeon and vertigo specialist at Apollo Hospital, Hyderabad. Dr. Jadhav will speak today on the topic of an overview on Merrill disease. Without a further ado, I'll hand over the session to Dr. Jadhav. Over to you, sir.
Thank you, Shreyas. Hello, everybody. This is Dr. Y.L. Ravi from Apollo Hospitals. So today we are going to discuss the diagnosis and management of Meniere's disease. Uh, wait a minute. Am I audible?
Yes, sir, you are totally audible. Your screen is also visible.
I'm not sure. The screen is not moving actually.
Okay, so sir, you can stop the presentation and start again. Share the screen again.
Yeah, should I stop sharing and then
Yes,
wait a
you
minute?
can stop sharing and you can again share your screen.
Yeah. Is
Yes, it's
the
visible.
screen visible?
Yes, it's visible, sir.
Okay, right. Yeah. So let us start with the anatomy first. So basically, Meniere's disease is an inner ear disease. So as we know that inner ear is divided into two components. One is cochlea, which helps us in hearing, and one is vestibule, which helps us in balancing. So vestibule has basically five parts. There are three semicircular canals, as you can see, the superior, the posterior, and the lateral one. Along with that, you have the utricle and the saccule. We know that in the utricle we have the otoconia, sometimes when it gets dislodged, it can lead to BPPV, that is benign proximal positional vertigo. Utricle has a unique function. Utricle and cycle has a unique function as they act as gravity receptors. So that is they help us in knowing it keeps our brain informed about our horizontal and the vertical position. Now there is a duct which is called as endolymphatic duct, which basically starts from the utricle and the sac here, and it ends into the endolymphatic sac. As you know that this duct helps in draining the endolymphatic fluid. The endolymphatic fluid is a fluid which is secreted by the stria vascularis. Overproduction, that is accumulation of the endolymph in the endolymphatic sac, leads to Meniere's disease. Now the theory is that either there is an overproduction or there is a defective absorption of the endolymph in the endolymphatic sac. So we are going to discuss about it further in our topic. Now, what is the function of endolymphatic sac and why it has to be there? So number one, as I said, it helps in resorption of the water content of the endolymph. Number two, it has ability to participate in some ionic exchange with endolymph. It helps in removal of the metabolic and cellular debris, including otoconia. It helps in the immunodefense function. It helps in inactivation and removal of viruses. It is also seen that it helps in secretion of glycoproteins to attract extra fluid. And it also helps in secretion of sacin to increase endolymph production. So Meniere's disease, it has typical features. Number one is it has a vertigo, which mainly lasts for minutes to hours. It also has a sensorineural hearing loss associated with tinnitus. The sensorineural hearing loss is generally seen in lower frequencies. Hearing loss is also accompanied with oral fullness. Whenever there is an episode of vertigo, it generally comes with nausea and vomiting. As we said, we can see, this is a normal endolymph where there is no overproduction or defective absorption of the endolymph. Here we can see there is a distended endolymph because of the overproduction or a defective endolymph. There is a valve which is called as a Bast valve. It is a utricular valve. Sometimes there is a theory that the dysfunction of the Bast valve can lead to a Meniere's disease. But exact etiology, it still remains unknown. So as I have discussed, Meniere's disease is a disorder of the inner ear characterized by hearing loss, tinnitus, and vertigo. In most cases, it is slowly progressive and has a significant impact on the social functioning of the individual affected. The importance of this line, that it is a slowly progressive, it means that the disease occurs in spells where it remains in active phase, followed by it can go into the dormant phase where the patient doesn't have a single episode of dizziness for a long period of time. But however, the hearing loss can become irreversible over a period of time along with tinnitus. Now there are current diagnostic criteria which has been proposed by Barani Society. These are the patient should have at least 2 or more spontaneous episodes of vertigo, with each lasting a minimum of 20 minutes to 12 hours. Audiometrically, we should be able to document low to medium frequency sensorineural hearing loss in 1 year, defining and locating to the affected ear in at least one instance prior, during, or after one of the episodes of vertigo. There should be a fluctuating oral symptoms like fullness, tinnitus located in the affected ear. And also they should be not better accounted of these symptoms by any other vestibular diagnosis. This is these are definitive criteria for the Meniere's disease. The probable Meniere's disease comes into these are the following criteria. There should be 2 or more episodes of dizziness or vertigo, each lasting 20 minutes to 24 hours. There should be a fluctuating oral symptoms like fullness, hearing loss, and tinnitus. and the condition should not be better explained by any other vestibular diagnosis. As we have discussed, the etiology is mainly because of the accumulation of the endolymphatic endolymph in the endolymphatic sac, endolymph fluid in the endolymphatic sac. So basically, the Meniere's disease can occur in two form. In the typical Meniere's disease, it can present as a vestibular Meniere's disease, or it can also present as a cochlear Meniere's disease. In the vestibular Meniere's disease, the hearing loss may not be impacted and there may not be any tinnitus. Only the dominating symptom can be a vertigo without any hearing loss or tinnitus. In the cochlear Meniere's disease, the dominating symptom will be the hearing loss, and vertigo or a spinning sensation may not be a part of it. It is very important because sometimes we come to the diagnosis that if there is a triad of hearing loss, vertigo, and tinnitus, definitely it is a Meniere's disease. But sometimes it may not be it may not come with hearing loss, or there may not be all the classical feature of all the Meniere's disease. So what helps us in really differentiating between these two? The answer is MRI, Meniere's protocol. Basically, it is a MRI of the inner ear with 3 Tesla MRI is the minimum strength of the MRI which is required. Below 3 Tesla MRI, it may not show us the exact pathology of the inner ear. Coming to the epidemiology, the prevalence of Meniere's disease varies between 3.5 per 1 lakh population to 13 per 1 lakh population, and it often occurs in the older white and female patients. The identification of several comorbidities which occurs in an increased fashion in patients with Meniere's disease gave rise to new theories about the origins of the disease. And the latest theory is that migraine can lead to Meniere's disease over a period of time. Now, migraine occurs more often in patients diagnosed with Meniere's disease, although there might be an overlap between the bacillar migraine, which could be wrongly diagnosed as Meniere's disease. Autoimmune diseases can again lead to a Meniere's disease over a period of time, namely rheumatoid arthritis, systemic lupus erythematosus, and ankylosing spondylitis. There are genetic, there are genes, there are more than 100 genes which can lead to a genetic reason for a Meniere's disease, and mostly it shows autosomal dominant or autosomal recessive inheritance, but it can also be a sporadic. That is, the patient's parents, there may not be any disease of Meniere's in the family, but the patient can have he can be the first person to have a Meniere's disease. Now, the association between the Meniere's disease and migraine is both an epidemiological and a mechanistic one, with up to 51% of individuals with Meniere's disease experiencing migraine compared to 12% in the general population. The presence of endolymphatic hydrops in those with Meniere's disease may be the factor that unites the two conditions, as hydropic inner ears have an impaired ability to maintain homeostasis. Migraine headaches are theorized to cause aura and symptoms by spreading cortical depression that ultimately results in substance P release, alteration in blood flow, and neurogenic inflammation. How do we examine when the patient comes to us with Meniere's disease? So in the emergency room or in the general practice, the physician will differentiate between vertigo of central and peripheral and the cardiovascular cause. The red flags for a central origin of vertigo are neurological symptoms or signs, acute deafness, new type or onset of headache, and pure vertical, torsional, or rotatory nystagmus. If Meniere's disease is suspected, the patient should be questioned about the character of vertigo, hearing loss, and earlier episodes. A full otologic history is a part of the clinical investigations. If Meniere's disease is suspected, one should perform a full otologic examination, facial nerve testing, and assessment of nystagmus with Frenzel glasses and tuning fork test. Now, the characteristic of the nystagmus in the Meniere's disease is that it beats towards the affected during the initial period of the dizziness. That means, like, if the right ear is involved and if there is a attack of vertigo, the eye beats, the nystagma beats towards the right side. That means the fast component will be towards the right side and the slow component will be towards the left side. But over a period of time, maybe after 12 to 24 hours, when the vertigo spells slowly weakens, we can see there is a reversal of the nystagmus where the nystagmus again starts beating towards the healthy ear, that is towards the other side. In our case, like as we said, the right ear is involved. So in this case, the reversal of nystagmus will be towards the left side. Head impulse test, head impulse test will show us whether there is any peripheral vestibular deficit, and it helps us in knowing how is the vestibular system functioning. Audiometric evaluation is mandatory in all patients with Meniere's disease, and there is fluctuating low frequency unilateral sensorineural hearing loss in the early days of the disease. The hearing loss can progress to all frequencies, and tinnitus is common, and it is generally restricted to affected ear. As I said, like all patients with one-sided hearing loss should undergo magnetic resonance imaging, and in our case, like it should be a minimum of 3 Tesla MRI with Meniere's protocol. How does it help? Basically, we know that we give a double contrast in this type of MRI. So we know that there is a perilymph and the endolymph. So perilymph has the ability to absorb the contrast, but the endolymph doesn't have ability to absorb the contrast. So we see that whenever there is a increase in the endolymph, there is a dilatation of the saccule utricle and the semicircular canal. This dilatation can be seen as a black, or we can see a perilymph around it in the form of contrast, which shows that it's a whitish thing which appears on the MRI. Vestibular function testing may show a significant underfunctioning affected organ in almost 42% to 72%, and a full loss of function in almost 6% of the patients. Computed tomography, this is also one of the criteria which has recently been discussed. So high resolution computer tomography and the three-dimensional reconstruction were used to detect the anatomical variables associated with vestibular aqueduct and jugular bulb in hydrops and non-hydropic ears. So jugular bulb was classified as type 1 to type 4. Type 1, no bulb. Type 2, the bulb extends below the inferior margin of the posterior semicircular canal. Type 3, it extends between the inferior margin of the posterior semicircular canal and the inferior margin of the internal auditory canal. Type 4, it rises above the inferior margin of the internal acoustic canal. Jugular bulb height and non-visualization of the vestibular aqueduct on wash plane could render patient susceptibility to the development of the endolymphatic hydrops. So vestibular aqueduct obliteration revealed in the three-dimensional reconstruction of the computed tomography is a specific radiological sign, and it may have the potential for screening causative high jugular bulb in Meniere's disease. Most of the time, by the time the patient comes and presents themselves before a doctor, the nystagmus may change its direction. That is why you can tell your patients whom you are suspecting Meniere's disease to record the nystagmus by their mobile phone, which can really help us to localize the disease and the pattern of nystagmus. The differential diagnosis of can be differentiated into three types, like central, peripheral, and the metabolic. The central causes could be acoustic neuroma, multiple sclerosis, vascular loop compression syndrome, aneurysm, vascular insufficiency, Arnold-Chiari malformation, cerebellar or the brainstem tumor, and transient ischemic attack or cervical vertigo. Peripheral, benign proximal positional vertigo, labyrinthitis, perilymphatic fistula, otosclerosis, and sometimes, as I said, migraine-induced vertigo. Metabolic being diabetes, hypothyroidism or hyperthyroidism, syphilis, Cogan syndrome, anemia, and sometimes autoimmune Yes. So this is again a criteria which has been uh, which has been described by AOHNS, American Association of Otolaryngology and Neck Surgery, which has already been discussed. Glycerol test helps us to know whether the possibility of Meniere's disease is there or not. If there is an increased endolymph volume, when we administer glycerol, which is a dehydrating agent, it reduces the volume abnormality and it results in measurable changes in responses, specifically when it comes to hearing and also when it comes to summation potential, which is recorded during the electrocochleogram. VNG testing, it helps to see to study and record the character of the nystagmus in the Meniere's disease. It also shows there is a reduced caloric response on the affected site, and it gives us a diagnosis that there is a peripheral vestibular lesion. Now coming to the management. Management basically starts with lifestyle changes, mainly in the form of salt restrictions. Then beta-histine. Beta-histine has been specifically prescribed or has been advocated for Meniere's disease, and beta-histine generally doesn't have any role in any other form of vertigo. And why it is helpful, we are going to discuss. Intratympanic steroid or intratympanic gentamicin also helps in controlling the vertigo symptoms. And at last, surgery, which includes a vestibular nerve resection, or it can also include a labyrinthectomy. As we have discussed, the basics of conservative management starts with salt restricted diet, followed by a diuretic, followed by a pressure chamber, followed by a surgery for intralymphatic sac, then the intratympanic injections, then the vestibular nerve resection, and the complete destruction or labyrinthectomy of the inner ear. So this is a treatment protocol. So vasodilators, along with symptomatic treatment, antivertiginous medicines, especially the vestibular sedatives, and antidepressant and the psychiatric treatment can also help in overcoming the disease. So coming to the dietary modification, there should be a low sodium diet, which should be typically like less than 6 grams per day. Caloric restriction has also been suggested, along with caffeine restriction and along with alcohol and the nicotine. Gluten-free diet has also been proposed that it helps in preventing the Meniere's disease attack. Specially processed cereals that increases endogenous anti-secretory factors synthesis have been proposed to improve symptoms of Meniere's disease, and the studies has been going on. So vestibular suppressant has a very minimal role. The main vestibular suppressant what we use is either cinnarizine or chlorperamazine. We don't want the vestibular system to sleep. So basically vestibular suppressants are only during the active form of vertigo, after which the vestibular suppressant has typically no role. Beta-histine. Beta-histine is a vestibular, it excites the vestibular system, and the typical dose is like, which is recommended is 48 mg to 72 mg for over a period of 3 to 6 months. Beta-histine works as a weak agonist properties at H1 receptor and more potent anti-antagonist effect at H3 receptor. It is the only non-sedating anti-vertigo drug. As I said, like we don't want the vertigo system to sleep. We want the vestibular system to wake up. That's why there is a minimum role of vestibular sedatives. Beta histone also have a unique feature which it helps in facilitating the vestibular compensation. The mechanism of action is like it increases the histamine release by H3 auto action. It increases cortical activity and it improves the circulation to the brainstem. The dose less than 48 mg has been shown that it has a less effectiveness when compared to higher doses of beta histone. As the study shows, the dose with 48 mg 3 times daily, the, uh, uh, the control of the symptoms is much better when it compares to the 16 mg, 24 mg TID, where the symptoms are not as effectively controlled. Now, what is vestibular compensation? So, vestibular compensation is a natural process by which the brain helps the body overcome the feeling of vertigo. It takes place mainly at vestibular nuclei, a structure which is present in the brainstem. The vestibular nuclei receives inputs from the 2 ears from each side. So, as we can see, this is the intact vestibular nucleus, and this is the damaged vestibular nucleus. Now, beta histone helps in increasing the levels of histamine in the vestibular nucleus by H3 autoantagonist action. It also increases the activity of the damaged vestibular nerve by H1 agonistic action. It also helps in reducing the inhibition by intact H3 hetero antagonistic action, as a result of which the compensation takes place. Now, we should know that the compensation of vestibular system may not be complete if it is not along with the vestibular rehabilitation therapy in many instances, and the compensation may not be complete for many patients. Many factors helps us like in the compensation whether it will be complete or not, age being number one, and the genetic makeup of a particular patient. Now, the overpressure therapy, in which the Menieres device has been advocated by the United States Food and Drug Administration. So basically, how the Menieres device helps is it by creating a positive pressure. How to use it? Basically, you have to do a meningotomy, and you need to insert a grommet tube. After inserting a grommet tube, basically you have to introduce the device, and you need to create a positive pressure. The positive pressure goes through the grommet tube into the inner ear through the round window, and it is believed that this positive pressure helps in opening up the endolymphatic duct, which in turn helps in draining the endolymphatic fluid and reducing the vertigo attack in the Menieres disease patient. Intratympanic dexamethasone has been shown like a very effective modality of treatment. The concentration generally uses from 2 to 24 mg per milliliter. There are many articles which has come over the intratympanic corticosteroids in Menieres disease, and all the articles, they generally speak like how effective the intratympanic dexamethasone therapy helps the patient to control the symptoms of the Menieres disease. Gentamicin is also a drug which helps us in controlling the symptoms of the Menieres disease. It has a vestibular, we know that gentamicin is a vestibular toxic, and 80% it acts like a vestibular toxic agent, and 20% it acts like a cochlear toxicity. So it comes with the risk of hearing loss. Now, gentamicin is particularly prescribed in Tumarkin's drop attack, where the patient has a sudden vestibular shutdown, which results in the fall within the few seconds. Any patients who has Tumarkin's drop attack, intratympanic gentamicin therapy really helps such patients to overcome these drop attacks. So again, like there are many papers which speaks about the efficacy and durability of the intratympanic gentamicin treatment. The dosage what we give is like 40 mg per ml gentamicin, and injections are generally given for 1 to 4 days depending on the severity of the disease. Uh, Now the recent update, it speaks about the intratympanic steroid injection along with the high dose of beta histine. It really helps in controlling the vertigo symptoms in a better way. The surgical treatment is basically a transmastoid endolymphatic sac procedure, transmastoid labyrinthectomy, retrosigmoid vestibular nerve resection, and there is also a procedure called as endolymphatic sac clipping. Most of this surgery comes with a little bit of morbidity, and the success of the surgery is really debatable, because even with the medical line of therapy with intratympanic injection, there is an effective control of the symptoms of the Meniere's disease. And as I said, like many a times that disease goes into a dormant form, just we need to manage it till it is active. So surgery is the last option. Many patients, they also prefer, because their symptoms are so out of control or so intolerable, that they would like to undergo a complete labyrinthectomy. In such cases, labyrinthectomy followed by probably uh, cochlear implant. They can restore the hearing, and it can also manage the Meniere's symptoms. So when you compare monotherapy with the combination therapy always shows that it has a better control. So the combination therapy is basically a beta histine and intratympanic steroid, and along with the sinerizine in the initial phase of the vertigo attack, it shows a better control of the symptoms when compared to the monotherapy. Thank you, friends. Yeah. If you have any questions, please go forward and ask me.
Yes, sir. So, sir, there are a few questions that have come up. The first
Yeah,
question
please
is,
ask.
could you discuss the relative merits of starting with conservative measures, diuretics versus more aggressive approach?
What is the exact question? Sorry.
Sir, the question is that
Mm.
the disease management involves a multi-prodigent approach. So,
Okay.
can you discuss the relative merits of starting with diuretics versus more aggressive approach for different patients?
See, it depends. It really depends on the symptoms which patient presents. Many patients have shown a better result with minimal, with a, like medical line of treatment, where it includes diuretic along with beta histine and along with uh, locally minimal invasive treatment like intratympanic steroid injection. And many patients, they do really very well. And I have not really required any surgery like to manage the Meniere's disease in like my practice. So I feel that that is the last resort, which you should really think about the surgeries. And even after doing the surgery, there are many studies which shows that uh, the results post surgery or the post conservative management is almost same. So I don't see that there is a extra benefit what we are gaining with the surgery, and we know that surgery is always invasive and it comes with morbidity.
Okay, so so the next question is, what advice do you have for managing the psychological impact and improving the quality of life of patients in terms of long term?
See, psychological means many patients, they don't know like what is the disease they are suffering, because once you give a diagnosis to the patient and you say that it's the inner ear which is involved, not the brain, that itself most of the times the patient gets they feels better by 50 to 60%, if not 100%. But like giving them the diagnosis and telling them and sharing your knowledge and teaching them about the nature of the disease and why the treatment is required and why there is a lifestyle change, what they need to do in terms of salt restriction and other thing with vestibular exercises. That really gives them a peace of mind. And once they know the diagnosis, more often than not, the patient really feels happy that it's not a major thing. But the vertigo spells can lead to uh, major issues in life, like accident during if they get a vertigo spell during driving and all. So we should caution them about that. But many patients, before having acute vertigo, they sense that the vertigo spell is going to come. They sense it by like there is a thickness in the ear, or there is an increase in the tinnitus before the start of the vertigo, and that really helps to settle down to one place and avoid the major accidents.
Okay, so the last question is, can you discuss the role of intra injections? I guess, sir, you have already discussed this in your presentation in terms of
Yeah.
steroid and gentamicin. And also, there's a question related to this, as it is a new treatment method, and have you used it or seen any sort of results yourself?
With
The use of steroidal injections, example, gentamicin.
yeah, like I routinely use it in my practice, intratympanic dexamethasone injection, and I have seen a lot of improvement in most of my patient. If I say like there are 10 patients, at least 7 to 8% sure, 7 to 8 patients shows excellent results. 1 or 2 patients may show a moderate impact, and 1 patient may not show a good result. But for those patients, we definitely have an intratympanic gentamicin injection, which can really help us to overcome the symptoms.
Okay. So, sir, that was all for the questions that were come up in the chat box. Uh, and thank you, sir, for addressing the questions seamlessly. Your expertise and abilities to answer the questions are so thoughtful. We immensely value this session, as our postgraduate students that are joined up today for this event must have benefited a lot. uh, uh, for the viewers that are viewing this webinar, we'll be sure that post this webinar, the expert talk will be available for your further reference. Meanwhile, you can submit your questions if you have in the chat box, so that in further future we can recommend and we can ask doctor again. Uh, on the behalf of
Thank,
everyone that has joined today, sir, we deeply appreciate your time and support, and sorry for the delay
thank you
from
for
our side.
having me. Thank you for giving me an opportunity to speak. Thank you for having me here.
Uh,
Hopefully, it was helpful to at least few of the people, and
yes,
they
yes, sir.
may always come back to me, and I'm there to help them if they want any literature wise or practically how we treat the Meniere's disease. So if they want my help, I'm always there to help.
Yes, sir. We deeply appreciate this presentation and also your efforts, sir, of overall. And looking forward for more collaboration. So on this note, I'll end the session. And if you have any few words, sir, you can elaborate.
I would like to say that Menisage is an excellent platform to share your knowledge, to share your expertise, and it gives you a platform to listen to many doctors and how they are practicing and what they are doing in their clinics or what uh, how they are different like in approach in terms of practice, and it really increases the horizon of the medical practice, and it really helps you like if you are regularly listening to lectures by your colleagues, seniors or juniors. It always helps you in learning the things.
Thank you so much, sir. Thank you so much. That was really thoughtful. And we'll surely connect again. Uh, everyone joining us today, wish you a productive day ahead. It is 10, but still, I guess many people are working or maybe going home. So, yeah. Thank you so much, everyone. Thank you, sir. See you again.
Yeah, thank you for having me once again.